And now I'd like to introduce Robbie Zimbroff, who will be our moderator for the evening. So please welcome him.
Thanks, guys. I'm Robbie. I'm going to be your moderator tonight. The resolution for the debate tonight that we're having is that for-profit healthcare is better for patients. And we're going to have this in three parts. The first part that we're going to have is we're going to have opening statements from both of the speakers, followed by 2 rounds of rebuttal. So each speaker is going to have 5 minutes for their first statement, followed by a 2-minute rebuttal, followed by a 1-minute rebuttal. Dr. Heller, since you, we took a poll while you all were getting dinner, and I have the results of that poll at the start of the evening. 68% of people in the audience were in favor, 28% were unsure, and 5% are in favor of free market healthcare. 68% are in favor of a national healthcare model. So, Dr. Heller, since you are the proponent, you have your 5-minute opening statement first.
Thank you. Good evening, everybody, and thanks for coming. So I'm speaking in favor of the proposition that for-profit healthcare is the best for patients. Franz Oppenheimer was a sociologist at around the turn of the previous century, and he wrote a book called The State, published in 1919. He wrote, "There are two fundamentally opposed means whereby man, requiring sustenance, is impelled to obtain the necessary means for satisfying his desires. These are work and robbery, one's own labor and the forcible appropriation of the labor of others. I propose to call one's own labor and the equivalent exchange of one's own labor for the labor of others the economic means for satisfaction of needs, while the unrequited appropriation of the labor of others will be called the political means." Oppenheimer, who, by the way, considered himself a liberal socialist, went on to write, "The state is the organization of the political means." So what is profit, if we're going to talk about for-profit healthcare? Well, it's pretty simple. Profit is the positive difference between the market price of a good or service and the cost of producing that good or service. And why are profits beneficial? First and foremost, because profits represent the net increase in value when goods are exchanged. Each party in a profitable exchange receives greater value than she gave. Although it is easy to measure profit in money terms when a good is exchanged for money, the receiver of the good also profited, having given up money that she valued less than the good obtained. Clearly, a net increase in value, profit, is better than a net loss or even breaking even. Profits have other benefits. They incentivize producers to satisfy the demands of consumers. Recall, too, that every consumer is a producer. They incentivize producers to become more efficient. Lowering the cost of production relative to the market price increases profit. They attract additional producers to satisfy unmet consumer demand, causing supply to increase and prices to decrease. By relying on price signals, for-profit transactions minimize shortages and surpluses. Profits achieve these benefits without conscious direction that requires overhead costs and coercion. By contrast, a non-profit system to provide goods is incentivized to satisfy the bureaucrats who manage it, not consumers. Such a system lacks incentives to become more efficient. In fact, the incentives in a bureaucracy favor inefficiency. A nonprofit system lacks incentive for additional producers to satisfy demand, and, as in single-payer systems, may even exclude them. By eschewing prices, shortages and surpluses are increased. And a nonprofit system requires a bureaucracy to manage, incurring additional overhead costs. So the question remains, because it's clear that profits are superior to nonprofits, don't we have a for-profit system? We don't. Our system is predominated by Oppenheimer's organized political means, the state or government. Profits require market prices. There are no market prices in our current system. There are subsidies, regulations, price controls, enforced oligopolies, licenses, and a surfeit of bureaucracies, but virtually no markets. Economists call the money earned by the actions of government rents to distinguish such income from the money earned by market transactions or profits. Our current system relies on earning money through the action of government, rents, not profits. The ills in our systems are due to government and rent-seeking, not markets and profit-seeking. So-called solutions like Obamacare and single-payer are simply more of the same that got us where we are today. Reducing reliance on government to organize the provision of health care, increasing the reliance on the spontaneous order of markets guided by prices set by supply and demand, and producers and consumers seeking profit, is in the best interest of all of us, not least our patients.
Thanks for having me. Actually, when I first arrived at Harvard, they told me that an expert is anyone who comes from out of town and brings along slides. So I'm living in New York, and just before we started, I was told it was inappropriate to show my slides, so you'll forgive me for not appearing very expert. The great free market economist Milton Friedman said that nothing could be worse than corporate officials holding to any responsibility other than to make as much money for their shareholders as possible. And the fundamental question ethically is that what we want, that ethic, what we want running our healthcare system? Do we want people to reject those, people who run our healthcare system to reject those elements of our work which are unprofitable? Do we want them to direct the activities of the institutions they run and their practices to only making a profit, or are we here to do good? Now, I won't stay at the level of ideology, but I'll ask you to attend instead to the level of evidence. Contrary to what Dr. Heller says, there is in fact very substantial for-profit participation and element in our healthcare system, and we have broad experience with what that means. About 28% of our hospitals are owned and operated by for-profit corporations, and the research literature is very clear that their death rates are highest, according to the sophisticated meta-analysis, about 3% higher caring for comparable patients than nonprofit hospitals. And their costs are about 19% higher. They spend less on nurses and all clinical personnel, but more on the administrative personnel who can help to boost the profit of the institution. We have that kind of evidence for HMOs, where for-profit HMOs that now predominate in our system in fact have overhead that is substantially higher than nonprofit. And on every quality measure that's been collected and every study that's looked at the question, more than a dozen now, for-profit HMOs deliver inferior quality care. In the nursing home sector, higher prices and lower quality care, higher mortality rates. In the dialysis sector, some 9% higher mortality rate. We sacrifice 1,800 patients each year in the for-profit sector who would live if we allowed them to be cared for by nonprofit dialysis providers. In the home care sector, we know that for-profit home care agencies, which increasingly predominate in our profit-driven system, in fact deliver worse quality as measured by the 23 quality measures that we collect, and their costs are about 9% higher than not-for-profit home care agencies caring for comparable patients. Well, why is this? It's because, in fact, patients are not effective shoppers in the realm of medical care. They are in no position to effectively evaluate the quality of the care that we deliver or to shop in advance when they have chest pain for which hospital they should go to care for them when they have a myocardial infarction. And in much of the country, we have no possibility of market competition. About half of the United States has insufficient population density to support two competing hospitals in its region. So competition and markets make no sense for at least half of the United States. Empirically, we've been running, in essence, two parallel demonstration projects in North America over the past 50 years now. We spent about the same per capita as Canada did in 1963 when its program was implemented, a simple national health insurance program, and our death rates were lower than theirs. Not only that, but the gradient between rich and poor was less steep in the United States than in Canada. And 50 years later, our spending is nearly double theirs, and the death rates in our country have soared far beyond theirs. And they've soared there because poor people do poorly in the kind of market-oriented system which is predominated in the US. In essence, we find that there are some things that are too precious, intimate, or corruptible to entrust to the market, and healthcare is one of them. We can't afford it. Thank you.
Thank you, Dr. Himmelstein. Dr. Himmelstein representing the opposition of our resolution tonight that for-profit healthcare is better for patients. So now we have our first round of rebuttals, which will be 2 minutes each. Dr. Heller, you have 2 minutes.
All right. Well, the objection that I mostly have to Dr. Himmelstein's statements is that he speaks about for-profit. As I pointed out in my opening, profits in this system are really not profits, they are rents. That for-profit, not-for-profit is a tax definition, not an economic definition. And that it's sort of a parody of a profit-making system, but in both cases, whether for-profit healthcare providers or not-for-profit healthcare providers, what they are doing is working to satisfy bureaucratic measures and not patients, which brings me back to something Dr. Himmelstein said in his opening, that corporations represent the interests of their shareholders. In fact, corporations, businesses represent the interests of their consumers, because without consumers, they have no business. The idea that patients can't participate in markets for healthcare is a myth. If patients truly can't determine what they want in a healthcare market, how are they supposed to elect politicians to appoint bureaucrats who are able to do that for them? They have no more ability to determine who can determine quality health care than they can to determine quality health care in the first place. Lastly, the statistics on death rates, comparing the United States to other countries, are not meaningful in terms of determining the quality of health care. The United States has a low life expectancy, particularly among young poor people, because of the war on drugs and the violence that entails, not because our health care is not up to snuff. How much time do I have? Thank you.
Well, tell Volkswagen owners that the firm works for them and not for actually the owners of the firm and in search of profits. And in fact, what we know is that in corporate culture, if you learn to cheat, you don't need to learn to be good at anything else. We know that in healthcare because on a variety of measures, we have ample evidence of cheating in a wide variety of institutions seeking to make a profit. And though Dr. Heller seeks to redefine the term profit in his own idiosyncratic way, in fact, there is a difference between a corporation whose shareholders direct it and legally the management is responsible to make a profit for those shareholders, and institutions that do not have their imperative in their charter. In fact, the vast differences in life expectancy in Canada, between Canada and the US, cannot be attributed to the relatively small proportion of deaths that are preventable because of that are caused by poor habits or social problems. And yes, we have enormous social problems, but in fact, Canadians drink more than we do and smoke more than we do. And if anything, the habits of the society influence the differences to Canada's detriment, not to ours. In essence, what he would ask us to do is to redefine what we know about profits and to create a system which would go back to one we had in the 1920s, where there was no regulation of medical facilities, where substandard care was the norm, and where charlatans won out in the marketplace.
Great. So now for final rebuttals, just before, maybe just from your seats, because these are only 1 minute apiece before we move into the second part of our debate. Dr. Heller, your final rebuttal.
All right. Emma Goldman, the 20th century anarchist, was known for saying, if voting changed anything, they'd make it illegal. The idea that a government-mandated and run single-payer system will eliminate the rent seekers, the hospital corporations, the health insurance companies, big pharma, the medical industrial complex, and divert all the money they gain to patients and doctors is pure pie in the sky. These rent seekers have come into existence and thrive by the political means. They control the government apparatus on which they rely, just as the military-industrial complex controls legislators and bureaucrats. There is no greater chance that the medical-industrial complex will permit itself to be socialized out of existence than the military-industrial complex will do so, and for the same reasons. On the other hand, deregulation of the airline, trucking, and telephone industries in the 1970s demonstrate it is both feasible and beneficial for consumers for the government to reduce its hold on large national industries. The problems incurred by heavy government involvement in an industry like healthcare can be mitigated by reducing that involvement, but not by increasing government involvement, and certainly not by wishing that government will oust private actors with huge economic stakes and resources from that industry. Reducing bureaucratic overhead can be achieved by eliminating the fee-for-service model, turning doctors into employees and hospitals into government facilities, a la the VA model. It is far from clear that that results in benefits to patients, as also demonstrated by the VA model. In any case, this kind of change is politically infeasible in the U.S. at this juncture. More likely, the fee-for-service model would be retained. Low bureaucratic overhead in the system results in high waste and fraud, as it does in the Medicare system.
Thank you, Dr. Heller. Dr. Himmelstein.
Yeah. Well, a couple things. One is that the portrayal of a national... Turn this on, I guess. The portrayal of the national health insurance as government bureaucrats dictating medical care is a bizarre portrayal to any doctor or patient in Canada, where in fact patients have a completely free choice of what doctor they go to, and physicians have far less interference in the practice of medicine than anything that we experience routinely in this country. Moreover, the image that we couldn't rid ourselves of the medical industrial complex is tantamount to saying our country is inferior to some 23 others that have successfully carried that out, where there are in fact no for-profit hospitals in Canada or most of Europe. There are no substantial corporate involvement in the delivery of healthcare in those nations, and they're better for it. The image that we can't do it in this country because the corporations have such a stranglehold on our country is hardly an argument that we should go back to a system completely driven by for-profits.
Thank you very much. So that ends the opening statements part of this debate. We're now moving on to a structured question and answer. Each panelist will be asked a set of 3 questions that they'll have 2 minutes to answer, followed by a 1-minute rebuttal from the other side. So Dr. Heller, since you're the proponent, we're going to start with you again. The first question, how can a for-profit system address the socioeconomic inequalities that have historically led to health disparities, particularly among the poor and minorities?
Only a for-profit system can do that. The incentives in a for-profit system to lower costs and increase quality is what drives things like cell phones to be available to people that we consider poor. The problem of poverty is really a lack of profit making, especially in this country where the government bureaucracy has a stranglehold on social welfare systems. There is no reason to think that a good as desirable as healthcare will not be made available by actors who are seeking to increase their market share. There is no reason to think that we don't have enough money being spent. The single-payer system advocates say we spend this tremendous amount of money. That money is available for health care. It's just poorly distributed, especially to rent seekers.
If I can follow up, because you have another few seconds of time, a majority of the currently uninsured are people of color. In the current system, is there any way to account for a for-profit system or a partially for-profit system where the uninsured are people of color?
The ability to discriminate on basis of race or gender or any other personal characteristic is reinforced by bureaucratic systems. Markets punish discrimination. Governments enforce it.
Thank you so much. Dr. Himmelstein, a 1-minute response.
So Dr. Heller keeps talking about these markets that punish discrimination and that drive prices lower. Yet he gives us not a single example in the healthcare sector that actually illustrates that this works. So he gives us examples on the manufacture of easily monitored consumer goods and things that it's easy to tell how they're made and what the price is. But in fact, for the vast majority of medical work, there is no such standardization or ease of monitoring. And he can't give us even a single example to back up with data, not with his suppositions and general arguments, what he claims. Not only that, but the administrative costs of the system that he actually would propose are enormous. And he gives us not a single piece of evidence that such would not be the case.
Thank you, Dr. Himmelstein. Now a question to you. Under single payer, the government would set standards for what good health is and would determine if procedures are worth spending money on. Why is this better than a system where patients and doctors make those decisions?
I mean, that's actually sort of a bizarre misportrayal of national health insurance programs. In fact, government provides the insurance, but in national health insurance programs, the insurer has been in real life far less interventionist than any of the insurance programs in our country. In a Canadian hospital, in a Canadian doctor's office, basically the question is, how long did you spend with the patient for the doctor? And you check one of 8 boxes on a billing form and send the billing form to the government that pays the bill. And they don't intervene in the question of what's the appropriate care to deliver in that circumstance. Hospitals are given global budgets. They run like a fire department in this country. And the insurance plans don't intervene to tell hospitals what you should do with the individual patient. What they do is say, what's the appropriate kind of provision of healthcare for this community that we need? And that's what we need in this country. We need to know what Harlem needs for its hospitals. We need to know, not hospital resources should follow the money, but hospital resources should actually follow the needs in the community. And that there's an appropriate role for government, just as there is in planning our water systems, in delivering fire services, and in many other services that we take for granted.
Thank you. Dr. Heller, your response.
Yeah, this brings up what economists call the problem of socialist calculation. That bureaucrats don't know how much health care people need. They can only set an arbitrary number, which results in either a surplus or a shortage. Luckily, surplus money is usually spent by people regardless of the need. In terms of an example, all you have to do is look at socialized systems in other places. Do you want to be North Korea? Or do you want to be the Soviet Union? Or do you want to be the United States? I don't have to provide a single example. How many of you use Uber? Okay. Before Uber came about, were you satisfied with the taxi service in New York? Did you have any imagination of how you could make it better? No. But markets bring those things about if they're permitted to operate. And there is no reason to think that the same won't work for healthcare.
Just my luck, Canada is the last communist country on the face of the earth.
Dr. Heller, sorry, I lost my spot. Dr. Heller, the second question for you. Isn't the for-profit system why insurance and pharmaceutical companies are able to exploit patients now?
Well, again, this is not a for-profit system. It is a for-rent system. For instance, pharmaceuticals. Most of you probably have read in the Times about this guy who, with Daraprim, the antibiotic that he's jacked the price up on from $10 and change to $1,000. And the reason he's able to do that is only because the FDA prevents anybody from competing with him. It prevents that drug from being imported from foreign sources, and it imposes enormous costs on anybody who wants to start up a factory to make more of it. So the exploitation is on the part of government and bureaucrats, not on the part of economic actors.
Dr. Himmelstein.
Yeah. So we should abandon the FDA and all regulation of drugs and allow anybody to sell anything and claim it's a drug. By that calculus, we ought to have allowed thalidomide, which caused enormous numbers of birth defects, but was kept out of the United States by the wisdom of the FDA in regulating our drug industry. And in fact, the problem with our drug industry is not over-regulation, but under-regulation, because there is no conceivable way of patients becoming effective shoppers and knowing in detail which drugs are useful, which drugs are dangerous, which copy of pyrimethamine, which is the generic name of Daraprim. I urge you to use generic names as you go through medicine. Which copy is in fact safe and which copy is fraudulent and ineffective. And in countries that don't have that kind of regulation, ineffective drugs are the norm. And again, I ask not for an example from outside of medicine and outside of the countries we might compare ourselves to, but a single example in medicine in an advanced developed country of a market that works in healthcare.
Thank you, Dr. Himmelstein. Your second question. If government is going to help the poor, why is limiting Americans to one healthcare option via a national health program or single payer better than directly giving them money via a health savings account?
Yeah. How many people in this room care that they have a choice of doctor? And how many of you care that you have a choice of insurance company as the key decision maker in the United States as long as your bills are paid? A few. It's the choice of doctor and hospital provider of care that is the essence. And their national health insurance systems provide a completely free choice. The alternatives of saying that patients should pay for their care, whether it's out of a savings account that they get to keep what's left over at the end of the year or directly out of pocket, first of all says we penalize the poor because the poor care what's left at the end of the year in a savings account or what's coming out of their pocket. The wealthy don't. And secondly, it penalizes the sick because the sick are the ones who will have to pay and the healthy are the ones who will be left wealthy at the end of the year. And thirdly, in the end, the insurance company, when that health savings account runs out, must in fact be the insurer because most of us have no chance of paying the catastrophic costs of a serious illness. And therefore, we will have private insurance companies. And the real choice is between an insurer that covers all of us on equitable terms or a private insurer that we have no conceivable say over in any realistic sense. We don't even have the right to go to their meetings or know what their decision making is, at least with our government, though I have grave doubts about our government and the FBI filed to prove it. We have some democratic rights.
Thank you, Dr. Heller. Your response.
Well, I share Dr. Himmelstein's distrust of government and its intentions with regard to individual Americans. I want to actually take a step back. The alternative to no government regulation is not no regulation. It is private market regulation. Organizations like Consumer Reports, the Medical Letter, UL, all participate in regulating and providing information on the efficacy and safety of all sorts of things. And there is no reason to think that in a market economy, those sorts of regulatory bodies will not rise. The question is whether you have a monopoly regulator that works for the benefit of pharmaceutical companies like the one that makes pyrimethamine, or whether you have competing entities that work for the benefit of their consumers, of their customers.
Thank you so much. Our fifth question of this second portion is addressed to Dr. Heller. How can a for-profit system address the needs of over 30 million Americans who are currently uninsured?
How could it not? There are people who are willing to buy things and want to buy it, and if there are willing sellers of those things, whether it be cars or cell phones or healthcare, they will meet in a market and come to a price that is acceptable to both of them. There is no human need that cannot be supplied in a market that's permitted to function. The reason that people can't afford health care is because of government interference in the market. It is because of the subsidies that continue to drive up demand, which drives up price, which prices people out of the market.
Can universal coverage be achieved under a for-profit system? Just as a follow-up.
I'm not sure what you mean by universal coverage.
Would it be possible for all people to be insured in a for-profit system?
Why do they have to be insured?
Okay. That's a sufficient response for me. Dr. Himmelstein, your rebuttal.
Well, Dr. Heller says buyers and sellers will come together in the market and agree on a price. What that's saying is your buying power in the market depends on how much money you bring to the table. And the fundamental question for us is, should your health care depend on your wealth? And if you think it should, then you'd be happy with a for-profit system. And if you think it shouldn't, then you would be unhappy with it. And if you think health should be distributed according to your wealth and your buying power, that's a very good way to do it, is to make sure that your attractiveness in the market depends on how much money you have.
Just as we do for food and shelter and clothing, things that are all more fundamental than health care.
And I guess the question for you as doctors to be is, do you want that ethic and that imperative to rule your work? Or
It doesn't rule your work. You can choose to be charitable.
Or do you want to actually take care of people according to their needs? Do you want to do good, or is the first priority to do well?
Again, a false dichotomy.
Thank you both. The last question. Mandating doctors, for Dr. Himmelstein, mandating doctors to accept government insurance infringes upon autonomy, but without a mandate, an unfair two-tier system will exist. Should doctors be mandated to accept government insurance under a national health program?
Yeah. Well, again, it's a slightly strange question because neither I nor, as far as I know, any other proponent of national health insurance in the country has suggested that doctors be mandated to work in the national health insurance program. What we have said is that it should be illegal to take the national health insurance from the patients who you want to, and then for the same thing charge others privately and more. So if you want to participate in the national health insurance program, you would be welcome. And in that case, for things that are paid for under that national health insurance program, you could not take money from elsewhere. If you want to practice cosmetic surgery on the side and that's not a covered benefit under the national health insurance program, you'd be perfectly free to do that as a plastic surgeon. But for the reconstructive procedures that are paid for, there we say you can't pick and choose unequally among people based on how much money they bring to the table. Or if you want to be completely in private practice and accept only cash payment, that's acceptable as well. But we also suggest that, like our current Medicare program, that it be illegal to sell insurance for things that are covered by the National Health Insurance Program. People would be free, as they are in Canada, to pay out of pocket, to pay doctors directly, and doctors would be free to accept private practice as their full practice for those patients, but not half in, half out. That does create a two-tiered system, which is unsustainable.
Thank you.
I see. So there are two-tiered systems. The question touches on Hayek's well-known road to serfdom. The more the government plans, the more people will not fit into those plans, and the more coercion government will have to use to make the plan operate.
Thank you very much. We're now moving on to the third portion of this debate, which will be audience-submitted questions. We have a few that were submitted online before this event, and I'm going to read two of them. Each of you will have up to 2 minutes to respond. And then we have a microphone on either side of the aisle, and then we'll take questions from the audience. So the first question, Dr. Heller, I'll again start with you. What is the ethical basis for how healthcare resources are distributed in each ideal model, a national program or a free market program?
Well, the ethical basis of a national program is force. Government takes money by force from those who have it and spends it on who it wishes to spend it on. The ethics of a market are cooperation and voluntarism. You produce, you can use what you've produced as you wish, and only as you wish. No one takes it from you, and no one spends it against your will on others. That's really the ethical choice.
Okay. Dr. Himmelstein.
Well, as I've said before, I think the real question is, do we want healthcare to be distributed according to need, or do we want healthcare distributed according to power and social position and wealth? And entrusting healthcare to the market assures that it is, as other commodities that are distributed in that way, as Dr. Heller has said, that healthcare should be distributed in that way as well. And unfortunately, that's not just to the detriment of the poor. We also have substantial data that it's to the detriment of the wealthy, that results in large amounts of unnecessary care. So we know that 30% of all of the cardiac stents that are performed in this country probably do more harm than good to patients. We know that substantial amounts of a variety of operations that are done of all types, virtually every type, are done for no good reason. And we know that for-profit hospitals like Tenet, the second largest of the for-profit hospital chains, do substantial amounts of unnecessary work. I mean, Tenet was doing open heart surgery on patients with no detectable heart disease.
All paid for by Medicare.
Because it was, in fact, extremely profitable. And if you think that would not be that they could not trick patients into paying for that because the cardiologist convinced them that was what they needed.
They tricked the bureaucrats into paying for it, let alone the patients. The experts were tricked.
They tricked the patients into undergoing the surgery. And if you think that the payment is more painful than the surgery, then I suggest you've not witnessed open heart cardiac surgery. And in fact, the for-profit firms and in general the profit motive in our society.
The point is the bureaucrats can't
Do I
pick
get to
out-
finish?
Please.
For-profit firms and the profit motive in our medical care to date is not only deleterious to the poor, but actually worsens the quality of care for the well-to-do as well.
Thank you. Dr. Himmelstein, would you advocate for stepwise implementation of a national health program or a total overhaul in the implementation? And then the same question to Dr. Heller.
It's really hard to cross a chasm in a couple of steps. So it's hard to see how you get to a decent healthcare system without making fundamental changes. So Obamacare, for the, I think, some good that it's done, has in fact, if anything, instilled our health insurance industry in an even greater control of our healthcare system. It's offered $900 billion in additional funds to the for-profit health insurance industry in this country. Unless we wrest control of our healthcare from the firms that currently control it, the health insurance industry, the for-profit provider industries, and others, we won't actually have a decent healthcare system. So I think we need to make a fundamental break. Maybe the one interim step that could be done, which is the way they did it in Canada, is to say that we're going to have national health insurance for all hospital care, and later then bring outpatient care into the system as well. I think that's problematic. It would be logistically difficult to do. It's conceivable that you could do it in a piecemeal fashion in that way.
Same question to you, Dr. Heller.
Well, I agree that Obamacare has done major damage to the economics of healthcare. As I said in my opening, I just don't see the healthcare industrial axis as permitting any sort of change, let alone a cataclysmic one. And as the folks in Vermont found out, it's just not feasible. The question is again, whether you permit bureaucrats to make your healthcare decisions for you, or you make them. And if the bureaucrats are doing it, the players will learn to game the system. They will be doing things that are against people's health interests. Because the bureaucrats are not interested in your health, they're interested in controlling money. When you make the decisions, you make decisions about your health based on what's of value to you. Bureaucrats can't reflect your values.
But Dr. Heller suggests that we're going to get the health insurance industry out of the healthcare system for his preferred for-profit system that doesn't involve
as I
corporate
said, you
actors.
can begin to deregulate the same way that airlines and telephone and trucking were deregulated, and they will still be in business. They will not resist because no one is threatening to put them out of their business.
Thank you. I want to actually ask one more question before I open it up to the audience. Dr. Heller, I'll have you answer first. Is there a solution where the incentive to invent and produce is balanced by equal access to care?
Well, that there is equal access to care. You know, in the Robinson Crusoe economy, the one-person economy, you can't consume what you don't produce. The myth that you can consume things for free based on government is false. It's just that government has taken the production of some and given it to others. But there is no free lunch, and you can't consume what isn't produced. The question is, do you get to use and direct your own production, or do you have it taken from you for the uses of others?
I'm sorry, could you repeat the question?
Yes, the question is there a solution where the incentive to invent and produce is balanced by equal access to care?
So, sort of incorporated in that question is the assumption that the incentive to invent and innovate is principally a financial incentive. And I find that offensive. So if you look at the list of who's won Nobel Prizes in the sciences, virtually none of them did their work seeking profit. In fact, most innovation in medicine, the vast majority of innovation in medicine, has had nothing to do with financial or corporate incentives.
They didn't starve either. They did their job. They worked.
And they worked not, I ask you not to interrupt me further, but they worked because, in fact, it feels good to be a good doctor and better to be a better doctor, and because it feels good to do good science and better to be a better scientist. My father was a cardiac surgeon who was the cardiac surgeon on the team that invented cardiac catheterization. And no member of that team ever thought of patenting that or ever sought profit from it. And that's true of virtually every other major invention in medical science in history. One of the distinguished graduates of this institution, Jonas Salk, the inventor of the polio vaccine, when he was asked, why don't you patent the polio vaccine, said, would you patent air? Our work is like air. It's what people need to live. And the incentive that we need is that we can do enormous good for our fellow human beings. We don't need the financial incentive to do that. We need to be comfortable and not worry about money.
Thank you very much. I want to open the floor to questions from the audience. We'll start over here.
Hi, I'm Zach. I'm a first-year medical student. I have a question for Dr. Heller. As I understand it, your for-profit model assumes that the patient is the consumer, and I feel like a lot of the time I'm really not the consumer of my own health care. I'm a college-educated, have done a little bit of a first year of medical school, but I feel like I don't really know how to make my own medical decisions. I feel like the person that really makes those decisions is the doctor. So my question to you is, who is the consumer in this for-profit model that you speak of?
Dr. Heller, just before you respond, I just want to make sure both panelists will have time to speak on this, and you have up to 2 minutes apiece.
I'm at a loss. The patient is obviously the consumer, and the patient is always the consumer. You are responsible for your health care, for your life, and for your well-being. If you're asking, how does the patient know, that's part of the doctor-patient relationship. That's why doctors have ethics and will work for the benefit of the patient. But doctors never work for free. They are either working because of their own personal values for non-monetary returns, or to make a living to feed themselves and their family. The idea that there's profit and then there's working for the good of whatever is, again, a false dichotomy. Everything that you choose to do, you do because you have a value in doing it. Whether, again, it's a charitable instinct or to feed yourself, you're making a profit when you exchange to do those things.
Well, I think the question really speaks to a very real concern about portraying patients as consumers. In fact, patients are at their most vulnerable when they're sick. They're in no position to comparison shop or to effectively evaluate what the care they're receiving, or to be at the mercy of firms or individuals whose primary motivation is market-driven. And when we ask patients to, demented elderly patients to comparison shop, what are we saying? We're saying that we send babes to the slaughter. When the distinguished, now late editor of the New England Journal of Medicine, when he was first hospitalized with esophageal cancer, wrote a moving essay about that he sought out, despite the fact that he was one of the world's leading experts on esophageal cancer, a physician to do the decision-making for him. Because he was not at that point in a position to effectively and intelligently do that decision-making. And he had to put his trust in his physician. And it was only after that that he could reach peace of mind.
Thank you. Move over to the other side of the room.
My question is also for Dr. Heller. Do you think that primary education, K through 12, should also be for profit?
The short answer is yes.
Could you please elaborate?
Again, the same reasons that anything should be provided on a voluntary basis, and that people should not use coercion to take resources from some and to provide goods and services to others. If you ask anyone in the Harlem Success Academies about whether public education has served their needs, I think you'll get a good answer from them about the role of public education.
And of course, the Harlem Success Academies are publicly funded schools. So sort of a slightly odd answer. But again, I ask for a single example in the medical care system, not of theoretical models of how things might work, not of examples from North Korea that have failed, but of a single example of a for-profit really, I mean, not non-private insurance, even non-private insurance model, the kind of model that Dr. Heller is apparently talking about, any evidence. So, you know, we're doctors. We don't just build models in the air of what we think might be true and then claim that that would work. We actually test our hypotheses. So what's the test of the hypothesis that shows that this theoretical model against which there is an enormous body of evidence actually has any chance of working?
Thank you. This side.
Yeah, so I have a question for both panelists. I'm just curious how each system would deal with the problem of externalities. So maybe in the for-profit system, how someone who chose not to buy insurance and had to go to the emergency room and had that cost borne by all, and maybe in the national healthcare system, if someone consistently made poor health choices that resulted in escalating costs, and again, the cost had to be borne by all. So if you could both speak to that.
Well, we already have the death penalty for the poor choices, so I think that's a significant enough penalty, right? If they shorten your life. And in fact, the vast majority of those, quote, poor choices are determined by your position in society. So we know that the vast majority of whether you're going to be a smoker or not is determined by the age of 17 in this society. So saying that we're going to penalize people or not take care of them because they grew up in a family of smokers and therefore became a smoker themselves is inhumane. Not only that, but in fact, the costs in our society largely are the costs of wealthy people who take good care of themselves because they live an enormously long life. And we have to take care of them for many, many years. So in fact, the wealthy get far more Medicare dollars than the poor in our society because they live so much longer, because the unequal lives in our society. So I'm perfectly willing to say that we'll redistribute some of our funds, and we have social solidarity, that we are responsible for each other even when we make mistakes, and we're responsible for helping our fellow human beings even when they make mistakes. And that helping people in trouble is part of what we do as a society. We're not just a collection of individuals. We're a collection of people who care for one another and try and work together to make this a place we all want to live. And if someone makes a mistake even, or a current mistake, I'm willing to pay a penny for it.
Thank you.
I'm not sure that what you're describing is an externality, but certainly the problem in the system that we have now, where healthcare is mostly paid for by taxation or by pooled prepaid funds like so-called private insurance, is that people can abuse the system. The answer in socialized systems and single-payer systems is that those people are generally penalized by the system. That, again, is why the more you socialize things, the more social control the government has to exert to prevent the system from going off the rails.
Homeless people in Canada, in fact, receive far better care, and there's very good data on this, than homeless people in the U.S. They're far from being penalized. But again, we're in a data-free zone.
Dr. Heller, I want to give you a chance to respond to that if you want.
Yeah, if the whole problem of being data-free, and this is a problem in proponents of markets, is, again, going back to the taxi system. If you said, what do we do about this taxi monopoly here in the city? How do we provide better transportation? And you asked that to a market proponent, the market proponent would have said, I don't know. And if he knew, he would have invented Uber or Lyft. But the answer is that markets do work. They have provided an incredible amount of wealth and comfort for people in the last century or two, compared to the historic norm, which is basically subsistence poverty. And that we don't have a market, but we know that in healthcare, but we know that markets work. And there is no reason that you have to say, well, gee, you have to do an experiment to do that.
Thank you very much. I want to take a question from this side of the room.
Thank you. I'd like to ask a question specifically on the issue of drug pricing and what's happening now. There's some discussion about the U.S. being able to negotiate drug prices for government programs, and I was wondering do you think that would happen, and if so, like what impacts would it have on people who have private insurance if it's negotiated just by the government?
Well, again, the problem with drug pricing is that the regulatory mechanism is captured by the pharmaceutical companies. And the last thing that pharmaceutical companies want to do is have to negotiate. They just want to have their markets protected. And that's what government does, is it protects the markets from competition.
So to answer your question more directly, there's very clear evidence that when governments are allowed to negotiate, that the prices do come down. Now, what we know is that the larger a proportion of the population has public insurance, the lower the prices are. So if government is able to negotiate for a large number of people, it does bring prices down. What would happen in the current situation where there's a mix of public and private insurance is a little bit unpredictable, but probably since private insurers are generally price followers in our healthcare system. So in Medicare, for instance, the Medicare law requires that hospitals give private insurers the same price that Medicare gets for Medicare HMO patients. It's likely that in fact those negotiated prices by government would bring down private insurer prices as well, though unlikely to as low as in countries that have national health insurance. And just to return to one thing about evidence on markets, we in fact did have a market-driven healthcare system in the U.S. in the 1920s and 30s and for decades before that. And it was a horrendous system. So it's not that we have no evidence, it's that we have considerable evidence. And the evidence is it doesn't work in healthcare. So we keep hearing about the evidence from other sectors. We have evidence in healthcare. It doesn't work.
Thank you both. Question over here.
So a question to both of you. You both have drawn analogies between healthcare and other services and goods to help us understand how you would imagine that healthcare would be delivered. So Dr. Heller, you've talked about goods like phones, services such as taxis, and also needs like clothing and shelter and food. And Dr. Himmelstein, you've talked about services like police or firemen and water. So my question is, what is your understanding of the nature of healthcare that makes it distinct from those other things to which you've compared it?
Well, I think there are some things that actually need to be universally distributed in our society, that every civilized society should make available to every member of that society. I think healthcare is among those, and that's why I use the analogy and why we say that justice should not be distributed by the market, and that kidneys should not be distributed by the market, and that life and death should not be distributed by the market. So I would actually favor moving towards lesser market influence in some other commodities in our society, and that I don't think that we should let people starve, as we in fact do in this country. We have huge numbers of people who are food insecure, and we in fact need, I think, to intervene in that market as well. I think TV sets are fine to let go and say the market should distribute those. That's a different thing. But the things that people need to live, those we can't rely on the market.
Yes, imagine if we had single-payer grocery stores. Wouldn't that be lovely? No, I don't see a distinction between healthcare. I think that the distinction is false, that healthcare is a good and service, a service like any other, like shelter, like clothing, like food, and that markets are the most efficient and just way to distribute those things for the reasons that I gave in my opening. let me go back for a moment to the medicine in the 1930s. You're talking about pre-penicillin. Yes, it was pretty terrible, but not because of markets. It was just the state of the science was. And the other thing about 1930s medicine, that's about the time the Flexner report came out. And
Flexner is 20 years before that.
well, 1920. But by that time, the American Medical Association had gotten licensing passed in all 50 states in the previous century, and hired Flexner to close down about 2/3 of the medical schools, which resulted in minorities and women being thrown out of medicine for the next 50 or 60 years.
So we should let anybody call themselves a doctor.
We should let anybody trade with anybody who they are willing to do so.
All right, it looks like we have one
Thank you.
more question.
Even trying to think about how to frame this question exactly, I think part of what is a core issue for me is understanding health outcomes as opposed to services. I mean, I think you mentioned that a fee for service can actually lead to poor outcomes, and so in that type of market, whether we say it's an ideal for-profit or not, the profit can actually be in favor of poorer health outcomes, not better health outcomes. So is that just that patients aren't educated? Is that an inherent problem with the way it's set up currently, or is that something that's automatically inherent to for-profit systems across the board? Could there be a for-profit system where you are paid not based on the service that you get, but based on the health outcomes that you achieve, as a physician?
Yeah. The problem with that idea, which is really pay for performance, is that separating the needle of performance from the haystack of other health determinants is essentially impossible. And we've been at this now for 40 years in health services research, trying to actually determine the contribution of a particular physician or even hospital to the health outcomes of their patients. And we now have a raft of studies showing that after 40 years of this enterprise, algorithms that try and say which is a good hospital. So a study in the New England Journal of Medicine that looked at 4 sophisticated algorithms to adjust for the patient's underlying risk and therefore say which hospital was good, reach completely different conclusions. So a hospital that looks outright dangerous by one method of adjusting for the patient's severity of illness looks brilliant by another method of adjusting for the patient's severity of illness. So the image that we can pay based on accurately assessing the individual physician or hospital's contribution to the patient's health is a lovely image, but in fact there is no empiric support for that proposition at this point. And all of the experiments in paying for performance have thus far reached the conclusion that we have not improved health by paying for performance. And there are now a number of those both in this country and in other countries, and none have achieved success. So in my view, there are a variety of bad ways of paying doctors. There are no particularly good ones. But if we're going to get good quality care, we actually have to depend on other things than financial incentives.
Well, if you want to talk about bad ways to pay doctors, you can look at what happened in London last week when 20,000 junior doctors rallied because they didn't like their pay. But yeah, the good thing about markets in terms of the question you asked is that markets are discovery processes. We don't know the answer. We don't know whether Uber works until somebody tries it. And markets, as opposed to bureaucracies, are excellent ways to try things. And that's how we make human progress.
Thank you so much. I want to thank both of the doctors for speaking with us. That ends the formal part of our debate. If we can just give them a round of applause to thank them.
And we're also running a bit ahead of time, which is great. And we're going to do a final voting now. So there's a gap right in the middle of the room. If you are to this side of the gap, can you pass your vote to the person who's sitting at the end of the aisle that side? And same for you guys, pass it to the person sitting at the end of the aisle this side. And just a reminder, green is for single payer, yellow is undecided, and red is free markets.
But I started with an enormous disadvantage. Most of you agreed with me to begin with, so
Right.
I couldn't win over very many.
Yeah.
Thank you.
Regression to the mean.
Really.
And while we're counting votes and collecting them, if either of you have any closing statements, maybe we could do that.
Sure.
All right. Starting with you, Dr. Heller.
Closing statement. I said my piece.
Okay, if you said your piece, that's fine too. Dr. Himmelstein, any closing thoughts?
Well, I mean, as I've said throughout, really the question is, what's the nature of our work? And is our work essentially something that we view as a trade to make profits from, that should be distributed based on who can pay us and who can't? Or is our work something that we view as furthering the health of the people in our society and our fellow human beings? And if it's the former, then you'd favor a for-profit system. If you want actually to improve the health of the population and to feel better about your work, I might say. I mean, it's enormously gratifying to not have to think about money and to actually take care of patients because that's what you love to do. Then we ought to create a system that allows you to care for people based on what they need, not based on their social position. And national health insurance is not perfect. It has problems. And government has problems, but we have no other mechanism for actually trying to get our profession and our work to those who need it.
Thank you both again so much. We're going to get those votes tallied as quickly as possible. Okay. So, Haran and Alice are going to come announce the final results.
Where's the initial vote?
Right there.
So to refresh everyone, initially 68% were in favor, 28% were unsure, and 5% were against single payer. After the debate, 91% are in favor of single payer, 9% are still unsure, and nobody's in favor of free market. Thank you so much for coming out. You were great.
Try and be rude.